Welcome. It's time. So take your time to just get settled and welcome to the week number 3 of a 4-week series. Each week, I'm glad everybody, well, the people that are here recognize that we changed the time for today. Each week we've been giving you a lot of information and building from one week to another. So I just want to welcome you here, and just thanks to the Bill Nelems Pain and Research Center that supports us to put on these talks. And today we have Dr. de Villiers from the center with us to start us off with some pain science and information. So just before we begin, just a little 1-minute exercise, just to put down your pencils or anything that you've got in your hands, and if you can, just put 2 feet on the floor. Sit as comfortably as possible in this moment, in these chairs. Relax your shoulders. Feel free to close or lower your eyes, and we'll just take just a moment to arrive with some of the deep breathing that we've been teaching over the last couple of weeks. So just to begin with, just become aware of your breath. So just notice, first of all, are you breathing? And as soon as you notice that, you probably start breathing, taking a breath. So just make your next breath be a little bit longer and a little bit deeper. So if you can, breathing in through your nose, out through your mouth, let your shoulders relax and your jaw, your eyes, forehead. And another deep breath in, filling up your lungs as much as you can today. Don't worry if it doesn't feel full. All to the bottom of your lungs, and a nice long, smooth exhale. And then one last one, again, breathing in as deeply as is possible for you right now. And on your exhale, just let go of anything that it took to get you here today, anything that happened this morning, and allow yourself as best as you can to be right here. Feel your feet on the floor right here. Good. Okay, so now welcome. So has anybody had any experience so far with a 1-degree course correction? Adding in breathing or having a conversation, dealing with a difficult emotion. Okay. So from what we've done so far in the last few weeks, we're going to build on today, on top of getting the right support, our discussion about difficult emotions and breathing and anxiety. And we have the honor of having Dr. de Villiers here to go back or move forward and talk about, that's not him, that's thank you to Dr. Etheridge, who runs the clinic, and talk about, and there they all are, and here we've got one of them live, understanding pain.
Thank you very much. So I just want to take 10 minutes and just go through a few concepts that I think has helped me a lot, specifically understanding the complexity of pain, and I hope that you will find some benefit from this. So if we look at everyone here today, I'm sure that you all, or most of you, have pain, and some of you may have shoulder pain, some may have low back pain, others may have pain all over the body, or chronic widespread pain as we call it. But the fact is that if we look at this picture there on the top, and I'm going to draw on the screen as we go along. If we look at the part there that says nociceptor, the pain impulse has to start somewhere. So let's assume, for argument's sake, it's a shoulder. So the pain impulse starts there, and then it spreads, and it gets sent to the spinal cord. It goes across, and then it gets sent up to the brain. And the brain, as you may have learned, gets all these information and then decide what to do with it. In chronic pain, it will interpret this as being painful, and then you get the pain experience. So as we know by now that you don't have pain until your brain recognizes it as being painful. Then what the brain tries to do is, there is the green pathway is called the descending pathway or the inhibitory pain pathway, and it tries to decrease, once again, at that level where it initially came into, it tries to decrease these impulses going up to the brain. That's how it tries to essentially control the pain. So that's just a basic cycle. Now, what happens with chronic pain in a lot of people, the belief is that if you have osteoarthritis of your lower back or anywhere, if you have myofascial pain, which you may have heard about before, a lot of people get whiplash injuries, they get muscle pain, muscle stiffness, that's called myofascial pain. Chronic widespread pain, fibromyalgia, even TMJ, irritable bowel syndrome. The belief is that those conditions are predominantly driven by the central nervous system. So, if you have chronic impulses coming in over a period of time, it may be 6 months, maybe 2 years, 3 years, each one is different. The spinal cord actually compensates due to all these signals, and it starts, two things happen. Number one, it produces more receptors to accommodate all these signals. And the second thing is, these receptors become more sensitive. So instead of needing X amount of force to get the signals through, it needs less. So the end result is you get this constant pain coming in, and instead of 1 or 2 impulses getting stimulated, more of these get stimulated. So you in fact have an increased sensitivity, and we call this central sensitization. Now, there are also changes that take place, similar changes in the brain. And as a result, this descending pain pathway that is supposed to block the impulses become less effective. So if you think logically about, let's assume you break a leg, that bone should heal within 12 weeks, maybe a bit longer. And if you're in a whiplash injury, we see most people, they don't sustain any significant injury, but they still have ongoing pain. So whatever happened there should have healed over time. So something else drives this whole pain cycle. And the belief is that it is this central sensitization. All right, how do we approach anyone with chronic pain? We can interfere on the outside. We can focus and see, is there a joint, is there a muscle or a ligament we can focus on? And hopefully, if we can block that impulse on the outside, the rest will go down. Or we can interfere there or in the brain. So, some of you may have been, or most of you likely have been at the pain clinic. We try and look for peripheral causes. Do you have a shoulder joint, a facet joint, or a muscle that we can inject? And the longer I do chronic pain, the more I realize that in the majority of cases, there is not just a single joint or two that we can inject that will control the whole system. It is not that simple. But that is where we start. So if you're fortunate enough that you have a single joint, we inject it, and the rest will calm down. The second place, as we mentioned, at the central nervous system. Now, we will talk about depression today. And the chemicals that the brain uses to try and decrease those impulses, there's quite a few of them, but the majority, or the most important ones, are called norepinephrine and serotonin. Forget the names, but it is chemicals that we also find in people in the antidepressant medication, number one. So a lot of times your doctor may say they want to put you on a drug, but it's an antidepressant, and people don't like that idea. But the whole rationale for doing it is not that it's got anything to do with depression. It is that those drugs work on this area. And if it can increase the effectiveness of that suppression, you will have less pain. And as Madeleine will probably discuss, or Madeleine, when it comes to depression, all right, so the same medication or the same chemicals work in the brain that helps you with controlling your depression. Then the third component is up in the brain. We know, and you guys have probably discussed this, that if you don't feel well, if you're anxious, or you feel depressed, or if you expect pain, or you've had previous pain experiences, all those things will not do anything for the joint, but it will increase your pain experience, or it may. So that's why one can interfere at those levels. Now, while we're on this topic, I just want to mention before I forget, we see a lot of people that come to the clinic and they want to know, where does my pain come from? And I think, one of the most important things is, if you have gone through injections, or you've done physiotherapy and you've seen chiropractors and massage therapists and you don't get better, I think one has to get to the stage where you have to move on from finding a cause for your pain and just focus on finding ways to manage your pain. Because you will get an X-ray or MRI that may show there's an arthritic joint or there's an abnormal muscle, but to prove that that joint is in fact causing your pain, it could be two different things. So it could be complicated, but I think that's a mind shift that is important. You've had your investigations. Don't go from one physician to another or another chiropractor. I think that's important. Move away from finding that cause and focus on how can one decrease your symptoms or control your pain better. Medication, just a quick topic there, or a discussion. Most people don't like to take medications, which is understandable. But at the end of the day, I tell people that, if you're willing to do a 6-week trial, that's all you need to do. You'll find within 6 weeks if it's going to help or not. If the side effects outweigh the benefits, then you stop the medication. You may get 20 to 30% reduction in pain, which is actually seen as successful in my mind, because if you get perhaps 20 to 30% reduction there, you incorporate the CBT that this lady has discussed with you, you do some activity, all those things combined may perhaps give you a 40% reduction. So the cumulative, multidisciplinary approach is important. So I think in my mind, sure, there can be side effects, but I think people owe it to themselves to give themselves perhaps a 6-week trial, and if it doesn't work, try something different. Then just the last comment I want to make on the CBT and so on. I realize that if people have chronic pain, you suffer, and it's not simple, but the multidisciplinary approach is once again important. Do the activities that you can. Don't overdo things, because you can imagine, if we keep that picture in mind, if you do too much, let's say you go for physiotherapy and it's really strenuous activity, or you do too much, a lot of people suffer for 4 or 5 days afterwards, and you may have experienced that. And the reality is, it is not because the therapist, or the injection is so painful. It is because this nervous system has been accentuated or activated to a certain extent, and that turns down. It takes a good 4 or 5 days, sometimes longer, to calm down. So in my opinion, you want to get an activity that you can do, that's realistic for you, that you can follow through with. Find your baseline, what you can do. If it means walk around the block, then that's where you start. And you gradually increase it, because over time we know that the activity will decrease your pain. So, just a last comment quickly before I'll let the ladies carry on. If you do too much activity, for argument's sake, let's just say you decide, I'm going to start walking 30 minutes, and I suffer for 4 or 5 days afterwards, what will happen is you will get a fear. You don't want to do this again. Let's face it, you suffer for 5 days, you're going to back off, you're not going to do your activity. That fear leads to less movement, which is normal. That less movement leads to weaker muscles, less stability, more pain, more fear. It's a vicious circle. So I think whatever you do, start slow or low, go slow. That's the reality. Same with medication. But look at the multidisciplinary approach, and you have to practice what they teach you. There's not a magic answer in chronic pain. Apply the strategies that they teach you, practice them, and the more efficient you get, I think the more success you will have at decreasing your pain. I hope it makes sense. You're right, you have to, you've got to spend the money, go and see a physiotherapist. You have to go and spend the money, go and see acupuncturists. Now, having said that, there is no evidence in seeing these people continuously, right? The idea is not to see a physiotherapist for the next 3, 4, 5 years, as we typically see people go through a vehicle accident, they go for 4 or 5 years, they come back and say it's not helping. That's not the answer. The passive treatment modalities only help you so far, but you have to learn from these people and incorporate what they teach you at home. So you have to get the knowledge, right? You've got to hear what they say. You've got to incorporate it in your own life. And if you get flare-ups, then for sure you go back and you go for treatments, etc. I think it's not easy, but that's one approach for sure. And then the second thing is you will get people that don't, I mean, I didn't know much about chronic pain 6 years ago. That's the reality. If you go to your family doctor and ask them what is central sensitization, I'll guarantee you that 8 out of 10 won't know what it means. So it's just because we don't get taught that in medical school. That's stuff that comes on later. So you have to seek for the provider that gives you some answers and which makes perfect or common sense, and then go from there.
I have a question.
Sure.
There's lots of ways by surgery, medical drugs of some sort to decrease the pathways going up to the brain. Any way to decrease going up? Is there any way to increase the message coming back now?
Yeah, so we know, and so just to recap quickly, in chronic pain patients, the belief is that descending pain pathway is not working effectively. That's the reality. So, all right. And I think this is where we know the medication can work in this area there, all right, and it can also work there. But the rest of these, of the focus to improve this descending pain pathway is where these components come in. The activity, right? The CBT components, cognitive behavioral therapy. That is at the end of the day, that's where you have to focus on. And some of the medications, like I say, it may also help. But once again, just on drugs quickly, my experience, it's not a magical treatment, all right? But keep in mind, if you get 15, 20% benefit, don't throw it out as a failure. Add it on.
Question. You talk about finding your base level
Yeah.
for activities. Now I'm on. Use the microphone.
The old thing of no pain, no gain, all right? That approach is completely wrong. Don't, because you will let pain be your guide, and that will push you into the sensitivity for 4 or 5 days. So just comment on that. It is not easy. I think you need to, what I would recommend is get a physiotherapist that knows chronic pain or a kinesiologist, right? Okay. Not just anyone, because, and we see this with personal trainers as well, they tend to, a lot of them tend to overdo it. So if you have someone that's got a background in chronic pain, they will keep the central sensitization in mind. I think that's a good step. Sure, there are days when you're going to get your flare-ups irrespective of what you do. I understand that, but I think you have to, if I say swimming is, for example, an activity, but you don't have access to a pool, then all right, let's leave that alone. But let's say you can. You start walking, or around the house. You do 1 block around the house, or you walk once around the house or the block. If you're okay 80% of the time, then that's where I would start. They say increase it gradually by 10% a week, roughly. And if you get a flare-up, then all right, then you may have to take a medication to help you during that period of time. But you've got to start somewhere. And for each one, it's different. But I cannot tell you in your case where you should start. If you tend to overdo it, then I would just start way down there and not be more on the caution side.
Okay, thank you.
But get help from physiotherapists, kinesiologists. That's what they're there for.
Okay. Thank you. I'd like to introduce Dr. Arun Ganesan from the pain clinic, and he's going to start us off with a little talk. Yeah, welcome.
Meet myself.
Good afternoon. How are you guys all doing? My name is Arun Ganesan. I'm one of the doctors at the pain clinic. Just a little background as to how I got involved. My background training is in family medicine, but then I did a year of anesthesia afterwards with a special focus or interest in post-operative anesthesia, regional anesthesia, where people would have hip or knee surgeries, and we would do blocks with the idea of decreasing the pain after surgery and getting up and moving better and getting involved with rehab faster with the idea of a speedy recovery. Then that was like 10 years ago. And then since then I've done family medicine, and I kind of didn't do too much of pain. And then about 3 years ago I met Dr. Bill Nelems, and when we were doing a hike from here to Penticton on the KVR, which got me sort of interested in pain again. And just my family medicine background, when I would have patients come to me with pain, I'd feel bad because the only thing I could offer was either a referral to someone or pain medication, which wasn't always very helpful. So I started doing extra training and got involved in the pain clinic, and that's where I am now. I've gone through this presentation. It's excellent. There's honestly nothing I can add more from my side. And if there's anything if you have any questions for me from a medical point of view, I'm happy to answer. Over the years, the name has kind of changed. They call it complex regional pain syndrome if it's in a certain area, or generalized complex pain, or central sensitization is what they call it now. Essentially, how fibromyalgia came up was you have pain that cannot be easily described. As you have generalized pain, it's not explained by any obvious injury to a certain area. So it was a diagnosis of exclusion. You do certain tests, x-rays, everything comes back normal. You don't know how to explain this. So then to put a name to it, that's how it came up. There were certain criteria, like you had to have pain in certain joints and so on. But that's kind of falling away right now. And yeah. In a certain area, yes. Yeah. So like I say, it's what they call central sensitization. So your entire central nervous system is sort of sensitized. So, for example, if the initial injury, or you had an injury to your hand from an accident, over time what happens, your central nervous system adapts because you have so much pain coming from the one hand. It evolves or changes, so you have extra nerves that are formed in the hand, extra pathways that send signals from the hand to the spinal cord and to the brain. And over time it evolves and changes, and then you can start having pain in other parts of the body, like the other hand or your leg or your chest or so on. It's very complex, and then it changes because things like weather will affect it, things like mood will affect it. If you're having a good day or a bad day. I don't know if you've heard some people say they can feel the weather change before they even know because their hand starts aching. So, things like that. And there's no one treatment. There's certain medications you can go on to help reduce the sensitivity. But it's more complex than that. You have to be, one, aware of what's going on, be mindful of it, and then try other strategies, including exercise, rehabilitation, yes, medication too. Yeah.
Try and rule that out.
Yeah, true.
Okay, so for those of you that were here the last couple of weeks, you'll remember that we call this course a 1-degree course correction. And the whole idea is, it's pretty much in a nutshell what Dr. DeVilliers was saying, is that one small little change, and the other thing that we've been sort of trying to focus on is to trust yourself and learn new strategies, learn new ways to deal with coping with your life and coping with pain. So Madeleine and I we're going to just kind of go through this. So today we're going to talk, we just did a quick review of how pain works. I'm going to talk a little bit about sleep, and then Madeleine's going to talk about depression, and a little bit about the mind-body connection and how thoughts work and how powerful they really are, that thoughts can actually cause chemicals to be secreted in your body that are helpful or not so helpful. And we're going to try to get to introducing you to moving safely again. So we're going to not do that break. If you remember, we're working from this toolbox. And to remember that all of these things work together. And so one area, if you can make a 1-degree course correction in one significant area, it's going to have a positive effect on all the rest of it. Just as a change in another area that's not so good can also have an effect as well. As you're saying, if you overdo it, it's going to affect everything, because it's one thing leads to another, it's all interconnected. So I'm going to talk a little bit about sleep, because sleep is really, really incredibly important in the whole complex of things that actually impact chronic pain. Let's say a good laugh and a long sleep are the best cures for anything. And sleep is something that should occur naturally, but how many people here have issues with sleep? Yeah. Very, very common. It's interesting that we cycle over our lifetime. Infants need much more sleep. As you get older, you need less sleep. And just even if you didn't have chronic pain in the mix, as you get older, you need less sleep, but sleeping is often an issue for older people. I certainly can relate to that myself. So one of the things to be aware of is that your sleep is affected by hormones. And if you notice on this graph, cortisol is a hormone that you require to be active, to be awake. It's a hormone that is higher in the morning when you wake up. And basically, it kind of goes down over time. Often, has anybody ever noticed kind of a slump, kind of a fatigue that hits around 2 o'clock or 3 o'clock in the afternoon? Yeah. That's kind of often the cycle where cortisol kind of goes down. And you hear when people travel and you talk about jet lag, and if you go to a time zone where it's a different light day cycle, then you have to take a few days to acclimatize so that you are awake at the same time that everyone else is. I remember just recently I was in Iceland just at the equinox, and it was 1:45 midnight, and it was daylight, and everyone was awake as if it was noon. I thought, wow. So the other thing on here is melatonin, and melatonin is a hormone that is released that causes you to get drowsy and to fall asleep. And so you'll notice as your cortisol falls at night, your melatonin rises. And so that's kind of the natural cycle where you need high cortisol during the day and low melatonin, and then the opposite at night. But one of the things that I found really, really interesting, I always thought you go to sleep at night, you sleep all night, you wake up in the morning. But actually, there's cycles of sleep. And if you notice, you start out with a cycle that you kind of a lighter sleep, and you go a little bit deeper and a little bit deeper, and then you come back up again. And so each cycle, you have non-REM deep sleep, and then you have deep, even deeper sleep, and then you have REM sleep. But what happens is that within 45 minutes to 90 minutes, you've gone through a whole cycle of sleep, and either you become light in the REM sleep, REM is when you actually dream, or you actually wake up. And it's actually very normal to wake up. And basically, it's just a light sleep, and then your melatonin will rise again, and you'll have another cycle. And for me, that was almost a revolutionary thought, because what would happen for me is when I woke up, I would you talk about the power of thoughts, I would panic. It's like, oh my God, I'm awake. That's it for the night. I'm not going to sleep again. So guess what? I was awake, and I didn't fall asleep again because my cortisol went way up, because my thoughts were telling me, this is terrible, this is bad, I'm awake. The moment I sort of learned that it's very normal to wake, all of a sudden I didn't have that experience, I didn't have those thoughts. And one of the things I talk about is each cycle is like a train that goes through. And so the falling asleep is sort of the engine of the train, and then you have each of the cars are the different stages of that cycle, from non-REM to very deep sleep to back up to REM sleep. And then there's kind of a latency where you actually wake up. So now, when I wake up and I realize, oh, that's okay, I'm awake, I'll just wait for the next train to come through, the next cycle. So it's just, talk about a 1-degree course correction, it's a cognitive awareness, a recognition of something I wasn't aware of, and it's made a huge impact on my quality of experience around sleep. So that's something to be aware of, is that it's really normal to wake up, and that as you go through the different stages of each cycle of sleep, it accomplishes different things. This is, I don't know if a lot of you have worked with a Fitbit. It's one of these things you put on, and it somehow, and I don't know how it does it, it can actually tell how much you're sleeping and what kind of sleep you're in and whether you're asleep or awake. So you'll notice it's supposedly 8 hours is what you're aiming for, and it will tell you that the darker bars are the deep sleep, the lighter bars are light sleep, and the orange is when you're awake. And so on your left, I got 55% of my 8 hours sleep that night. But what you'll notice is a lot of it were the light bars, the light sleep, and there was a couple of deeper sleep, but not very much. And the other one, I got 96% of my 8 hours of sleep. And although there's light bars, it's a much higher percentage of the deep sleep, the other bars. And for me, in my experience, when I had more deep sleep, I could really tell the difference. I really felt better. I felt more rested than when I had not that much difference in terms of the length of sleep, but more light sleep and less deep sleep. So again, it's just to realize that, there's different. What I also find interesting is that I think over time, I know our daughter was doing these as well, and when she would wake up, she would almost all light sleep, very little deep sleep, and apparently that's normal for a younger person. So,
what was the difference for you for those 2 days being up?
What was that?
What was the difference going into your night that night?
That's a really good question. Yeah. Just we're gonna talk. So many different things affect the quality of sleep that you have. Yeah. So one of the things that's really important is light, and to understand how much light impacts your ability to sleep. So the light comes in through your eyes to the optic nerve, and there's something called the suprachiasmatic nucleus, which is basically your sleep switch. And so in order for you to be able to sleep, you actually need darkness. And when I say darkness, I mean total darkness. So we're talking sometimes you have like the charging button on your computer or on your phone. And when the room is really dark, that can actually produce a lot of light. And so it really makes sense to do things like have blackout curtains and make sure that you actually have no light at all. So sleep is where we fix all the systems that are under stress when we're awake. It's hard to overestimate how important sleep actually is to the whole entire complex of things that affect not only your chronic pain, but just your experience of life in general and your emotional state. It impacts every major system in your body. And without sleep, your systems will actually fail. Your brain, metabolic system, cardiovascular, your respiratory system, intestinal, reproductive, thermoregulatory, endocrine system, and your immune system. So it absolutely affects everything. I'm sure you're aware with your emotional well-being, when you don't have enough sleep, that sense that you have a very short fuse. It's something that most of us are kind of aware of. But your social and emotional life, particularly REM sleep, it helps to recalibrate your emotional functions in your brain. It helps to process memory, and it keeps our emotional and our social lives on track. So this is a brain scan, and the little red dot that you see inside the green section there on the top, this is what they call the amygdala. This is the part of your brain that affects your emotionality. And you'll notice it's just a little tiny dot there when it's kind of the sleep control. But on the second one, you have sleep deprivation. So I'm not sure exactly how much, whether they went all night without sleep, but you'll notice the amygdala has lighted up there. It's about 3 times bigger, and it's bright. So, I mean, it's something you can actually visualize. This is another example of the sleep control, where you can see the little 2 dots are the amygdala, which is kind of your emotional brain. And then with sleep deprivation, it's lit up. So if you imagine, so we have daylight and we have darkness. In the daylight, our cortisol is higher, melatonin is low. Darkness, melatonin rises, and our cortisol falls. But what happens when we have daylight savings, or when we turn on the lights? So, the sun has set, so it's dark outside, but it's not dark in our house. We turn the lights on. And so that also affects our sleep. So one of the things that's helpful to understand is that blue light is actually the component of light that turns off melatonin. And blue light, as you know, you probably notice in computers and TVs and those kind of electronics, there's a high percentage of blue light. And so there's actually a software thing that you can download that will cut out the blue light in your computer or on your phone, so that you can still, because the best thing is to not be on your computer or have a TV in your room or have anything that's producing light like an hour before you go to sleep. But for those of us that have a hard time with that, you can actually download something, so even if you're on the computer, you don't have blue light coming into your brain. It switches off the blue light. So it basically blocks that part of it. So you have in front of you strategies, sleep strategies. And basically, if you can have a routine of the kinds of things that you do every night before you go to sleep. And if you remember, again, not all of these are going to work for you. It's about trusting yourself. It's about looking at the kinds of things that are being suggested and thinking, yeah, this makes sense to me. I'm going to try this. And again, it's not to be overwhelmed by this huge list of things, but to remember that 1 or 2 things that you try could be a 1-degree course correction. And if you do something that affects sleep, it can affect the entire system. It can actually have a positive effect on everything else that happens. So I would invite you to take a look at that sheet, and even if you pick one thing and say, okay, I'm going to try this and see if this impacts my sleep.
It's working? Good. Yeah. Good. Okay. My glasses. Okay, so the next part, time goes by fast, that we're going to talk about gets into the part of the toolbox. It talks. You've heard of people say a few times CBT. Is anybody really wondering what that is? Okay, cognitive behavioral therapy. I got it right. Okay, here we go. All right. So we're going to talk about CBT, lifestyle changes, and I don't think we'll get a chance to talk a bit about moving safely, but we'll put that into next week. So just going back to that pain spiral that we've talked about a few times, about how sleep affects our mood, or if we're not getting a good sleep, that I think has a direct impact on our mood, which then affects our activity and our energy level, which therefore stops us, decreases our mobility, and has the potential to increase our pain and weaken our muscles and generally not feel so good in body and mind. So all of the suggestions that we make and all of the 1-degree course corrections intervene somewhere in that pain spiral. And it's going to be a little bit different with each one of you, how and where you intervene. And all the suggestions that we make also affect the descending inhibitory pathway, so how our brain interprets and then sends messages back down into the body, which affects the pain experience. Can't see a thing on here. Okay, here we go. So just talking a little bit about depression. Now, this triangle will show us, just in a sample of chronic pain patients, it probably doesn't come as a big surprise that 50% of people that live with chronic pain also experience depression, which is probably, it's a little bit higher than the general population, but even out there in the general population, a large, I think 20 or 25% of people live with depression or have experienced depression in their lifetime. So I hate to say it's unfortunate, but there's quite a large percentage of people, and I think the World Health Organization has predicted that by 2020, it'll be the #1 cause of disability. So it's really important for the general population, but even more so if you're living with pain, to start to find ways to shift your mood, shift your brain, and improve your quality of life. So depression and pain, as Dr. de Villiers already said, often go together, and that probably, again, doesn't come as a big surprise. But there are reasons for that. First of all, depression is more than temporarily feeling down or unhappy. So I think we can all say that living with persistent pain makes it very difficult not to feel down or not to feel unhappy at times. But depression involves physical, emotional, and psychological symptoms that are consistent for at least 2 weeks, if not more. And that's just a general definition. So I'm just going to run through symptoms of depression. And this may, again, not be new news, but you may see things in there that you've identified with over time. So obviously a depressed mood or general irritability, a lack of interest in the activities that you previously enjoyed. And again, it's hard to kind of sift out what's pain and what's depression, because it's hard to enjoy activities when you're in pain that you previously enjoyed. Changes in your sleep pattern, so sleeping a lot less, you just can't sleep, or sleeping a lot more. Changes in your appetite, eating a lot more or eating a lot less, weight gain or weight loss. Feelings of guilt or despair. Often people find with depression that their minds are rarely in the present moment. We talked about anxiety being where our mind is focused on the future, and it's usually a fearful future, a future of uncertainty. Well, in depression, often people's minds go into the past and generally kind of delve around in the past a lot more, things that didn't go well, things that they might have done differently, different choices, and spend a very little time in the present moment. What was that? Could have, would have, should have, yeah. And it's normal to reflect, to go back and reflect on our lives, but it's different to go back and spend a lot of our present moments back there. Yeah, coulda, woulda, shoulda. A general lack of energy and difficulty concentrating, and it also affects our memory, difficulty remembering. And at times suicidal thoughts. I'd rather not be here. Yeah. So the good news is that depression can be treated, and this can help to ease your pain. And as Dr. de Villiers said, the same neurotransmitters are involved in chronic pain, the serotonin and the norepinephrine, as are involved in depression. So which is why it makes it really important if you are thinking or feeling that way for a long, consistent period of time, to talk to your GP or talk to your pain specialist and see if that's another doorway that you can come in to ease your pain and to feel better generally. So, any guesses? Why would depression be common for people living with persistent pain? Because it hurts. And it's really difficult, I don't need to tell you, to be happy when it hurts. Your activities, you can't do anything, you're less mobile. Others? reasons? Yeah, it hurts. Friends, did you say? Start to go by the wayside. Sure, social life changes or decreases. You end up spending a lot more time by yourself. So changes in your lifestyle, and that affects your mood greatly. Changes in your lifestyle and activity level. Those numerous losses, activities, friends, employment, isolation, social isolation. Stressors, things shift and change in our relationships, our financial situations, our social and societal, the expectations of the people around you. And you may have, Mary Ellen touched on her session earlier, previous sessions, you know, when people make statements like, well, you don't look like you're in that much pain, or don't understand why you're not able to come out with them that evening, or why you just don't seem like the same person that you were before, because things have changed. And misunderstandings about pain and depression and the just get over it mentality make it very difficult to live with. Because chronic pain and depression are so intertwined, that they're best obviously treated together. And what I've found many times is that sometimes people who live with chronic pain say, well, of course I'm feeling this way. It's because I have pain. Well, yes, for sure. So you may be less likely to go and talk to your doctor about it, assuming that it's part and parcel of what you're dealing with. But the good news is that effective tools, the medications, sometimes antidepressants, and lifestyle changes exist to both relieve the symptoms of depression and to be able to better manage the chronic pain. So don't discount it completely. I did have another one there. It's a slide. Let's just go back to that for a second. So in your handouts, I think I put a handout in there that is just a review from last week about anxiety, and then also some simple lifestyle changes for depression. So again, we're talking about a 1-degree course correction. The first one might be to communicate with your healthcare professional or to your team. So again, to your GP or your pain specialist or your physiotherapist. And sometimes even just being able to voice it and put it out there can start to help you to feel better. Or you may have put it out there a number of times already. But if you haven't, sometimes just putting it out there, you know, there's a saying, name it to tame it. Kind of, it puts it out there, talking to someone else about it. This is how I'm feeling. If you do, often this is the way that psychologists approach depression with a technique called cognitive behavioral therapy, or CBT, and you will often find that in the treatment of chronic pain as well. So it's helpful in the treatment of depression and also of chronic pain. And I'll just give you like a little kind of just a brief snapshot of what it is and how it works to affect that downward pathway. So it looks at how our thoughts or our thinking patterns affect us emotionally and physically. So has anybody here noticed throughout the course of your lifetime that your thoughts have almost a direct pathway to how you feel, either physically or emotionally? You've seen that direct pathway? Yeah. They say, I don't know where, I think it's much less than this, but I did read once that it takes a thought less than 20 seconds to reach the physiology, your tissues, say, in your body, so how you actually feel, the sensations that you feel in your body. So, and this is not, CBT is not a way of saying just think positive and everything will be okay, because we just know that that's not possible, and nor is it helpful. So there's many different thinking, what in CBT you call thinking distortions, so negative thinking patterns that we almost naturally fall into as a way of trying to cope, as a way of trying to protect ourselves from something that feels very uncertain and feels potentially dangerous. Okay? So one of them that you may hear coming up in CBT is catastrophic thinking. And this is really common when there's so much uncertainty and lack of control. Our minds go to, you remember we've talked about a few times, the fight or flight, the stress response. We go into a protection mode. And part of that mode is thinking extreme, negative, worst-case scenarios, sort of negative thoughts. Okay? So if you have noticed this in yourself, I want to tell you that it's common, and I hate to say it, but it's a normal way of trying to deal with a potentially, with a very uncertain situation. I say it's normal and it's common, but would you say that it was helpful? We'll see. Let's see. CBT helps to shift our thoughts to be more helpful and constructive. So when we get into patterns of catastrophic thinking, the only reason that we talk about this in a pain management course is because we know that our thoughts can directly affect our experience of pain. Just like any thoughts, like you've noticed that connection from here to here. It directly affects the sensation in our body for a number of reasons. Again, our limbic system, our amygdala that you saw earlier, which is involved in the limbic system, which is activated when we're in fight or flight. Okay? Catastrophic thinking activates that part of our brain. So that's the only reason that I'm talking to you about that today. So catastrophizing is a pretty strong word. What I like to call it is it's an extreme negative dialogue. It's a dialogue with emotional charge that feels really, really true, right? It feels really true, what you're thinking. Again, this is a normal reaction, but not always helpful. So I want to just kind of describe this with an example of, so I had a client once, and we'll call her Mary, who had quite severe back pain from a car accident that she'd had previously a few years ago, which always visited her first thing in the morning and woke her up. And before she even opened her eyes, the thoughts would start. I don't know if you've experienced this yourself. The thoughts of, I hate my pain, this is excruciating, it's ruined my life, I don't know how I'm going to get through my day, I can't stand it. Anybody had thoughts like that when you're in pain? A really normal reaction to something that's been life-changing, right? So she started to notice this pattern of thoughts that was happening even before she had a chance to put her foot on the floor. When that happened, she noticed a direct relationship to her pain. Her pain, as she slowed it down and noticed, she noticed the thought pattern and that her pain in her back increased. And made it far more difficult to actually take her foot and put it on the floor and get out of bed. So as we, over time, slowed down what was happening actually in that thought process, because you probably, the next question is, well, what do I do when that happens, when I find myself there? What she started to do before this started getting going, because it really felt real, like the thoughts felt really true. She said, okay, I'm just going to do 5 minutes of belly breathing before I evaluate anything. Okay? So before she even started to really buy into her thoughts, she would lie, put her hands on her stomach, and just do 5 minutes of the breathing that we've been doing. Okay? And then she started to notice, yes, her back pain was excruciating, but when she slowed it down, it was it was her lower back, but her upper back was actually okay. Okay? And then she noticed, well, actually, her right hand is not in pain. So she's already widening the scope. And then she started to notice, this is moment to moment, breath to breath awareness, that her pain was changing. Okay? So it would come and it would go. It was always there. I shouldn't say it would go, but it was isolated to this part of her back. And then she was able to see that there were other thoughts that were also true. Okay? So when she brought in a mindful awareness to it, she could see that yes, her pain was excruciating. There were moments and mornings that were really difficult. But she also knew that not all of her was in pain. She also knew that her pain changes. And she also knew when that thought, I can't stand this anymore, she knew that she was going to be able to cope because she's coped so far. So, can you see the difference between those two sets of thoughts? Both of which are somewhat true. Okay. So when I say, let's just try this out. When I say the thoughts out loud, I can't stand this anymore. I hate my body. This has ruined my life. How does that feel? It feels true. It feels really, really true. And how does that feel in your body? This is beginnings of the mind-body connection.
Feel it in your gut, your stomach.
Almost like a nauseous or like a heavy feeling. Doesn't feel so good.
The question is, does it feel like a choice that you think that thought? Does it feel like you're choosing that thought, or does it feel like that thought is just
automatic?
Because I think one of the things that Madeleine's talking about when you slow down is you start to notice that you do have choice. But when a thought is so automatic and comes so quickly, it doesn't feel like you have choice. And so the question is, if you don't know you have choice, do you have choice? Maybe not. But as you learn and begin to realize that you do have choice, then you can start to choose different ways of thinking.
This is a practice, probably for all of us, a lifetime practice, and it's never perfect. So like Mary Ellen was saying, when we can slow it down and notice what our story is, then we start to, and even after the fact, because boom, sometimes it's just there before you open your eyes, right? We can start to shift and change our thoughts simply so we don't set off such a loud danger signal, if that makes sense. Yeah. So being able to just slow it down and become aware of what happens. So as I'm talking right now, there may be thoughts that come up for you that are in reaction to your pain. Is anybody kind of getting one story right now that keeps coming up? Or one thought in reaction to pain? Okay. So as I'm going along, if you notice, this is my story, 1, 2, 3. These are my thoughts. Just take a moment. I encourage you, if this is your 1-degree course correction for this week, to actually just write them down. So you're going to be able to notice them when they come up and perhaps shift to a more helpful response. Okay. Yeah. So when we have pain, physical pain in our body, we have a reaction. Okay? We have an emotional, a psychological, and a cognitive thought reaction. When we can slow it down and notice what our thoughts are. For example, when Mary woke up, these were her 3 thoughts, or these were her thoughts, and they were always the same ones. It might not always be the same ones, such as, I hate this pain has ruined my life, and I don't know how I'm going to make it through the day. So if they're usually the same thoughts that arise not from person to person, but in each situation throughout your day. if you're able to label them and write them down, you're going to be able to better recognize them when they come up. Okay. Were you going to?
Sometimes I think the thoughts are almost unconscious, that sometimes they're on the interface between your conscious and unconscious mind. And so to write them down is powerful because sometimes you're not really even aware of them. When you write them down, it's like pinning a bug to a board. It's like you notice it. And that's when you can start noticing choice. Okay, so this is an automatic thought that I have that just kind of emerges when I'm aware of the pain. But when you write it down and you see what you're saying to yourself, is that really what you want to keep saying? And there is a choice. You can say something different, and you might want to just, again, the 1-degree course correction, just shift it a little bit. Even sometimes that phrase, this is what I'm telling myself, it reminds you, it's your perception, it's what you're telling yourself, and you have a choice. You could tell yourself something different. Something slightly different might have a different impact on how you feel. Yes, Connor?
Can you just maybe, in your example, Madeleine, what did Mary say instead?
Yeah. So once, good question. Once you start to notice what your reaction is and if it's helpful, how, is it helpful or not? How does it feel in your body? In the example of Mary, what she started to notice instead was that she knew, yes, this pain is difficult. It has changed her life. That's accurate. These are the facts. So it's not about ignoring what is there, but it's separating the facts from the reaction. Okay. And again, this is a lifetime practice. So she started to notice, yes, she is in pain, but she knew that her pain changes. She made a plan before she even got out of bed to breathe and make sure that she took regular breaks, even every half hour, to sit and rest throughout her day, and shifted her thoughts so that she knew she was going to make it through the day, okay? Because she always had, right? And yes, the pain was there, but she knew that it shifts and it changes. And she knew that there were parts of her body that were not in pain at the same time. So what did her actual thoughts become? I'm just trying to remember. I can make it. This pain changes. And that the other thing that she started to do was to schedule in at the same time. So it's being able to kind of look ahead. She began to schedule in one thing she knew she was going to enjoy that day. So that's what she would focus on. So already she's shifted something, however small. Does that make sense? Yeah. So it's changing your automatic reaction that's right there to a response. How am I going to do this? In a way that's most helpful. Okay. So for where we are in this course, I would say if you could pinpoint 1 or 2 thoughts this week that come up for you around your pain, that's already a course correction. Okay. So why am I spending this time on the thoughts? Because the thoughts are powerful and they can actually prevent us from, they can shift our experience of pain, but they can also prevent us from being able to move a little more freely through our lives. I'm wondering if do we need a 2-minute break or should I keep going? Do you feel like you need a 2-minute break right there? Or should we just go right through to the end?
Yeah, just go.
We're going to go. Okay. So the last bit of this is talking about the fear avoidance cycle. So how does this change the way that we approach our pain and how we're able to start moving again? So without getting too complicated here, you can see in the middle, there's your pain experience. Okay? When we go into automatic response, fight or flight, we can go into those catastrophizing thoughts, which actually, take Mary for example, increase our fear of movement. It's frightening. Right? and our worry about re-injuring ourselves or increasing our pain. Well, when she's experiencing, my pain is excruciating, do you think she's going to want to get up and move freely? No. No, in fact, she's going to want to stay in bed. So fearing re-injuring herself can increase to hypervigilance, which is being on alert, anxious, easily startled, tense, which leads to avoidance behavior. So this is a really tall task, to ask someone to slow down and keep moving slowly towards something that could potentially increase pain and potentially feels dangerous. It's a tall order. So let me back up. Getting out of bed, fearing movement, or re-injuring is going to make anyone want to avoid those activities that could potentially increase pain, right? Like, just, it makes sense. Unfortunately, then, we would move more towards not using our bodies as much, disability or depression. The other way that everything that we've been talking about is moving towards lowering our fear levels in our bodies and in our minds, okay? Which then allows us to move slowly and safely and within our window of tolerance, and that can be a bit of trial and error, okay? Overdoing, underdoing. Can anybody relate to that fear avoidance cycle? I mean, I think it probably happens to almost anybody with chronic pain. Yeah.
I don't know, I'm not really getting it, because I guess I'm opposite almost of this. When I get that pain, which is constantly, like you got that 8 or 10 pulse time of the night, my first thought is breathe and move.
Okay.
I don't, so I'm not really understanding this.
Okay. Well, that might be a good thing, because breathe and move are two things that are, I think you may have found through experience, that are going to calm your nervous system and that are helpful. Okay. Yeah. Do other people wake up when they have pain, breathe and move? Okay, some.
I've always thought that if I'm lying still for a long period of time, like sleeping, and I've got pain, then maybe getting up and moving, improve.
And has that been your experience? Absolutely.
So, like what you're saying is something that I've always been taught and try to practice on, right?
Okay.
Call it a positive thing.
Yeah. To think positive, yeah, which can be really, really difficult at times. But if you've practiced it your whole life, it becomes a little bit easier. Okay. So I think that we're hearing two people who have practiced this most of their life, or at least for a long time, and it does become the default over time. Yeah. So breathing, you're talking about positive thinking, and moving some to help your body. Did somebody?
Breathing, I let my mind go to a very quiet scene.
Okay.
I've had from my childhood.
Okay.
And it's something I like. The memories from it and breathing and thinking about.
Okay.
It helps. At least
Yeah, so using visualization actually can, using your imagination, shift and change the way that you feel in your body. Remembering a safe place, remembering a peaceful place, actually changes your feelings. Yeah, absolutely. That's, again, the power of the mind. Was there another comment here?
So, to me it seems like, all these things, I don't understand it either, because my best thing to do is just surrender. Sounds like we should be planning to get up, planning to close, planning. And I find that that's just too hard. So if I just surrender, give up, I give up. And then I think I go into a more relaxed state. So it's just a different way
Yeah.
that I'm doing it.
That's a really, really, really good point. To give up the fight, it sounds like. To what this woman is saying here is to surrender and give up. Is your words, and I know that's not, you're not giving up, but you're saying, okay, I surrender, this is what I'm experiencing in this moment. I'm not fighting. And for you, it sounds like the day then goes a little bit better. Or at least you're entering it into a calmer state. Yeah. So it is exactly that. Looking, in the end, it is looking at exactly what is happening in that moment and saying, this is what's happening for me right now. I mean, if it works for you to just relax into that moment and stay there, then that sounds like it's what's going to be helpful.
I would say that's more of giving in.
Yeah.
Or
Yeah,
acceptance.
yeah,
I would
acceptance.
say it's an acceptance of this moment. In this moment, this is how I feel. I might feel different in the next moment.
Yeah.
But I like that idea of not fighting, that, it's sort of that go with the flow kind of sensation where if I can accept where I am in this moment, then I can also accept that my pain changes and I can accept the next moment and the next moment.
And ultimately, that is what it does actually come down to, is being able to say, this is what's happening in this moment, and this is the next one, and I'm going to take it moment by moment. And we're going to talk a little bit more about this next week, breath by breath, and slowly, without the mind overreacting or the nervous system overreacting. And that's going to be our guide that we can always go back to as we learn to move again. Okay, so being able to accept exactly what's happening and notice your thoughts, notice your body, and notice your breathing, and then moving from there. Okay. Were there other questions about that, or anything else about this that's come up? So again, it's going to be a little bit different for everybody, but moving safely is going to require calming the mind. And what I mean by that is just noticing the thoughts that are coming up and calming the body with your breath in order to move within your window of tolerance, which is going to be a little bit different for everybody. And there are going to be days where, as you probably have noticed already, where you overdo and you pay for it. And there's going to be days where you don't challenge yourself at all. So being able to find that window of tolerance, which is what we're going to move into next week. Okay. So small lifestyle changes. Counseling and support from a therapist can help if if you do find you're thinking kind of circular and negative a lot of the time, or the catastrophic patterns. And on the handout, there's some other very small lifestyle changes around depression, anxiety, to make that 1 degree course correction. And again, like Mary Ellen had said earlier, to pick 1 or 2. So let's take a quick moment. I'm going to leave you with one more breathing pattern that calms and regulates the nervous system. So again, when that fight or flight or stress response creates some imbalance, being able to come back to balance so that we can monitor ourselves a little bit better as we talk about moving next week. So again, just find yourself in that, as best you can, in a comfortable place, in your chair. Preferably 2 feet on the floor, and if it works for your back, to be supported with the back of the chair. And if not, just sit however you can find yourself right now, as comfortable as possible. Feel free to lower or close your eyes. And just notice after our discussion, just bring your attention back to your breath and just notice your breath right now. And are you breathing? Does it feel shallow or does it feel a bit deeper? And when you're ready, just exhale completely. And then take a deep breath in, deeper. And one more full exhale. And just expel the air right to the very end. Then in, 2, 3, 4, and hold your breath, 2, 3, 4. And out, 2, 3, 4, and hold, 2, 3, 4. And in, 2, 3, 4. If you can, hold, 2, 3, 4. Exhale, 2, 3, 4, and hold, 2, 3, 4. A couple more. In, 2, 3, 4. Hold, 2, 3, 4. Out, 2, 3, 4, and hold. Relax your jaw. 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, relax your shoulders. 3, 4. Hold, 2, 3, 4. 2 more. In, 2, 3, 4. Hold, 2, 3, 4. Out to 6, 2, 3, 4. All the way out, 6. And let it go. Just take a moment. Just breathe normally. Just 2 more deeper breaths. And then just gently open or raise your eyes back to the room. So that was a box breathing that's often taught for chronic pain. And it's something you can do anywhere that you see. If you are out and about, you can do your breathing. Or if you find yourself getting stressed or tense, and you can also always find a rectangle anywhere and follow the rectangle of a window or a door. And practice your deeper breathing to calm your nervous system. All right.
So yeah, I would invite you to just think about one positive thing that's accurate but positive that you could say to yourself. Be aware that you are talking to yourself, dialoguing inside of your mind all the time. In terms of a 1-degree course correction, is there one thing that you can shift or be accurate but more positive about what you're saying to yourself in the next week?